Hey everyone, welcome to this masterclass explainer on the incredible, intricate terrain of the eyes and ears. If you're looking for a really direct, visual journey taking you all the way from basic sensory anatomy straight through to advanced clinical assessment, well, you are in exactly the right place. We've got a lot of ground to cover, so let's not waste any time and jump right into it.
All right, here is our roadmap for today. We're going to start by mapping out the normal anatomy of both the eye and the ear. Then, we'll dive into detailed assessments of the ear, followed by the eye. And finally, we'll look at diagnosing the flaws when abnormalities actually occur.
Section 1. Mapping the terrain. Anatomy of the eye and ear.
So think of the eye a lot like a super advanced camera. When we look at its cross-section, you'll notice it's constructed of three really distinct layers of tissue, all working together beautifully to receive visual stimuli. You've got the outermost layer, which gives the eyeball its rigid form. That's the transparent cornea and the protective sclera. Then, moving inward, you have the middle layer. This includes the choroid, the ciliary body, and the iris, which is actually where involuntary muscles control your pupil size. And finally, the innermost layer is the retina. This is the absolute crucial area that actually receives the visual stimuli and sends those signals straight to your brain.
Now the ear, it's basically a highly complex sound funnel. Just trace how vibrations travel. They start out at the flexible external ear, or the pinna, which collects the sound. Those vibrations then hit the tympanic membrane, which is what separates the outer and middle ear. From there, the middle ear conducts those vibrations deep into the inner ear, which is this crazy closed system of fluid-filled spaces tucked inside the temporal bone. It's right here, in structures like the fluid-filled cochlea, that those physical vibrations actually stimulate nerve impulses. Those impulses then travel all the way up to your cerebral cortex to be interpreted as sound. It's pretty amazing when you think about it.
Section 2. Detailed assessment of the ear.
Okay, before we even pick up an instrument, let's talk about what we're going to see in the external canal. We need to talk about earwax, or ceramin. The absolutely crucial point here is a fascinating genetic reality. You're going to encounter varying amounts of ceramin, and its presence does not, I repeat, does not indicate poor hygiene. The type of ceramin a patient has is literally genetically determined. Dry ceramin, which looks gray and flaky, is mostly found in Asian and Native American patients. On the flip side, wet ceramin, which is dark brown and moist, is way more commonly found in black and white patients. Knowing this normal variation is absolutely key to doing a competent assessment.
All right, let's get into the physical technique. When you perform an otoscopic exam, you really need to follow these precise steps. You want to insert the speculum super gently, only about 1/3 of its length down and forward into the ear canal. But here is the most important part, step 3. You have to avoid touching the inner canal wall. You have to be exceptionally careful not to touch either side of the inner portion of the canal because, let me tell you, it's covered by a thin epithelial layer that is incredibly sensitive to pressure. The goal here is a smooth, painless journey to view those structures.
So once you're actually inside, what exactly should a normal eardrum look like? Well, you're looking for a tympanic membrane that is pearl gray, glistening, and transparent. And here's a fantastic anatomical trick using a light. Look for the light reflex. In the right ear, that reflection should sit right between 4 and 6 o'clock. In the left ear, between 6 and 8 o'clock. You also want to look for bony landmarks. For instance, the malleus will show up as this dense white streak sitting right at 12 o'clock. Memorizing these normal baseline markers is exactly what allows you to spot trouble instantly.
Section 3. Detailed assessment of the eye. We always start any eye exam with the basic external positional check. Using the scalp line as your starting point, the eyes should naturally sit about 1/3 of the way down the face, and they should be exactly one eye's width apart from each other. Moving in a bit closer, you need to assess the external structures. By having the patient look up and just gently pulling down the lower eyelid, you can properly inspect the bulbar conjunctiva. You want to see that it's clear and shiny, and definitely note any excessive redness or exudate. At the same time, doing this gives you a great view of the sclera, which should naturally be a healthy white or kind of a buff color.
Next up, we test the pupils. Normally, they should be perfectly equal in size, round, and about 1/4 the size of the iris when you're in normal room light. Now, when you slightly darken the room and shine your pen light from about 20 inches away, coming in from the side, you are looking for two very specific reactions. First is the direct response. That's the constriction of the pupil you are actively shining the light into. But equally important is the consensual response. This is the simultaneous reaction of the opposite, untested pupil. Both of these absolutely must occur for a normal finding.
Okay, ready to dive deeper into the intraocular structures. The ophthalmoscope is your best friend here.
Now, don't let all those dials intimidate you. It's actually quite straightforward once you get the hang of it. By adjusting the lens disc, you literally travel visually through the depth of the eye. You use the green, positive numbers on the dial to focus on near, anterior objects, like if you're looking for clouding on the cornea or the lens. Then you just switch to the red, minus numbers to focus your view deeper on distant objects, way at the back of the eye, like the retina.
And here is exactly what you're looking for when you use those red numbers. This is a direct view of the retinal fundus. You can clearly see the optic disc, which should always be this creamy pink to yellow-orange color with really well-defined borders. From there, if you move your light laterally, you'll locate the macula. Notice how it appears as a darker structure that's completely free from blood vessels? That's actually the part of the eye that is the absolute most sensitive to light.
Section 4. Diagnosing the flaws. Eye and ear abnormalities.
First, let's look at decreased visual acuity. It is so helpful to directly contrast the most common culprits, which are refractive errors. In myopia or nearsightedness, the patient's vision at a distance is blurry. Conversely, in hyperopia or farsightedness, it's the close-up view that becomes blurry. Identifying which specific distance is impaired is really your very first major clue in any visual assessment.
Now, beyond just refractive errors, there are some major structural pathologies we need to be aware of. Let's rapid fire through these key ocular abnormalities. Cataracts involve a literal clouding of the lens, which often results from trauma, diabetes, or even certain medications. Then we have macular degeneration. Remember that vessel-free dark spot we looked at a minute ago? Well, when that deteriorates, it causes a severe, irreversible loss of central vision. And the dry form of this is the most common culprit in patients over 50. Diplopia, which is double vision, happens when extraocular muscles get misaligned. And finally, glaucoma. This is marked by increased intraocular pressure, and it famously causes patients to see visual halos or rainbows around bright lights.
Let's shift back over to the ear for a second to look at a very common pathology. I want you to mentally compare what you're seeing here to that healthy, transparent, pearl gray eardrum we discussed earlier. This bulging, highly inflamed, red tympanic membrane vividly illustrates acute otitis media. It's a painful inflammation of the middle ear that usually results from a disruption in the eustachian tube. Basically, it causes fluid and pressure to build up dramatically right behind the eardrum.
And, as you might guess, when structures in the ear are inflamed or blocked, it severely impacts function. This brings us right to hearing loss. Several physical factors can interfere with the ear's ability to conduct sound waves. It could be something as simple as an obstruction in the canal from a severe buildup of cerumen, or it could be fluid thickening in the middle ear from the otitis media we literally just looked at. It might even be otosclerosis, which is a hardening of the bones in the middle ear, or just sheer physical trauma. Ultimately, any of these mechanical disruptions can stop sound waves from ever reaching the inner ear, and that leads to significant conduction hearing loss.
Wow, we've covered a massive amount of ground today, from the outer anatomy right down to the retinal fundus and the deepest parts of the inner ear. As we wrap up, I want to leave you with this final thought. How will mastering these internal visual assessments transform your ability to detect critical hidden abnormalities in your everyday patient care? Seriously, consider how applying these structured diagnostic skills will directly empower you to catch hidden pathology faster and with so much more confidence. Keep practicing these visual assessments, trust your landmarks, and as always, keep learning. Thanks for joining me on this explainer.